हाँ
तो उसके नाम अनाउंस कर देंगे क्यों आ रहे हैं।
हाँ ओके। ठीक है, एक कंपेनियन हो गया रेडी किया, ठीक है। आई थिंक वी आर ऑल सेट नाउ। यस।
गेट सेट गो।
यस। Good evening, all of you. My warm welcome to this 253rd edition of Thursday Musings. Today, we are having back Dr. Ritvik to talk on procrastination from a clinical perspective. Now, the meeting is being recorded. This recording will be available on our YouTube channel. You can join this channel for other recordings. The questions are invited in the chat box. So you can type your questions, put in the chat box. We'll take it up to the presenter. Everyone will be on the mute mode. And yes, that's all from my side. Next slide, please. Handing over the session to the chairman of this program, Professor Dr. Tufan Pati, sir. Over to you, sir. Please take over.
Thank you, Dr. Lim. Thank you for inviting. At this, I also record of my appreciation for all our vibrant moderators, Dr. Lim Siddiqui himself, Dr. Amrit Patudoshi. Shreya, please move on the slides. Dr. Shobit Kar, move on, and Dr. Vishal Chabra. All the four vibrant moderators make this program successful. I have to introduce the chairperson, Dr. Gopal Das. He is professor HOD of Psychiatry in Dr. Chandramma Dayananda Sagar Institute of Medical Education and Research, Dayananda Sagar University, Bangalore. His areas of interest involve psychosomatic medicine, genetic mental health, affective disorders, psychopharmacology, technology, and psychiatric interface, medical education, and particular outcome competencies, training and research, technology, and medical education. Has 12 publications and ongoing multidisciplinary research projects in the areas of artificial intelligence and virtual reality with mental health interface. Our scholarship in psychiatry, teaching for teachers, ITUP steps in the year 2020-21 by Minds United Trust and Indian Teachers in Psychiatry Forum. Contributed chapter titled The Art of Addressing Adolescents in Dermatology and Aesthetic Practice. In the book called Essentials of Psychiatry for Dermatology and Aesthetic Practice, and another chapter titled Sleep Disturbance and Coping Strategies in a book titled The Art of Caring, Emergency Minds and Concept Book. He has worked as editor in 3 magazines, news editors of the scientific and public awareness interest, and conducted multiple workshops and positive lifestyle and stress management at many corporate and academic institutes over the last decades. Fellow of Indian Psychiatric Society, fellow member of Indian Association of Private Psychiatry, life member of IMA, member of Association of Health and Professional Educators. Next slide, please. Dr. Jay Singh did MBBS from Lucknow and MD from Lucknow, KGMU both, and works as KGMU experience in Lucknow. As associate professor, affiliation ERAS Lucknow Medical College and Hospital. Years of experience 10 years. Areas of interest specialization de-addiction, neuromodulation. Number of publications 15, book chapters 2. Welcome, Dr. Jay Singh. And with this, I hand over the meeting to the chairpersons and request Dr. Jay Singh to kindly introduce the speaker of the evening and introduce the topic. Yeah,
Okay, good evening, sir.
yeah,
Am I audible?
quite audible, please.
Okay, thank you very much, sir. And thank you all. Very good evening to all of you. And first of all, thank you, Dr. Tufan Pati sir, Dr. Alim sir, Dr. Amit Patojoshi sir, Dr. Sobit Garg sir, and Dr. Vishal Chabra sir for providing me the opportunity to be a part of this Thursday Musing, which is a wonderful platform for webinar. And today we are on, I think, 253rd edition of this Thursday Musing. So today's topic for the Thursday Musing session is procrastination. which we all know that the thief of your time. So the topic is procrastination from a clinical perspective. So if we go into the definition of procrastination, it is the tendency to avoid or delay acting upon a task or activity under one's immediate control. Procrastinators persistently postpone and avoid or undertaking completing tasks or making decision. And there is a lot of reasons these people give to procrastinate. Some are like fear, they fear of failure because of the perfectionism. They find difficulty in doing the task and because of the fear of success and low self-esteem. And for better understanding, I think it is good to give you a recent experience which I face for understanding of this procrastination. What is procrastination? Recently, 2 days ago, Dr. Vishal Chabra called me, contacted me, and requested me to chair today's music session, which is scheduled in just 2 days. And as soon as I heard about the request about chairing the session, many thoughts started coming to my mind. And by the time I was not even brief about the topic, what is the topic? And the thought which were racing into my mind were, how can it be possible for me to prepare myself in less than 2 days? The thought which came to my mind were that tomorrow I have OPD. After busy OPD schedule, it will not be possible for me to chair at 8 p.m. My clinic usually ends at 9 p.m. How will I finish my clinic before 8 p.m.? So this request has to be declined. And I'm very busy right now, so I apologize with this comment and many more endless thoughts coming into my mind. My mind started giving me a lot of excuses to avoid this task. And it does not mean that I was lazy at that point of time, or I'm not capable enough, or neither am really that much busy. And it was the procrastination thought which were coming into my mind. My purpose of giving this example is to make it clear that procrastination is not solely illness or a disorder. It is part of normal human behavior. We all procrastinate in some manner, but it may be associated with some psychiatric illness like depression, OCD, anxiety, ADHD, anxious avoidant personality issues, or personality problem, phobic disorder, and stress. And in our day-to-day clinical practice, we often encounter this symptom reported by the patient, our procrastination. So proper address of this situation is necessary. And for this, we have our esteemed guest today with us as a speaker, Dr. Ritvik Chatterjee. And Dr. Ritvik Chatterjee did his MD and postdoctoral fellowship in child and adolescent psychiatry from Topiwala National Medical College and B.Y.L. Nair Hospital, Mumbai. He was the winner of J.C. Marfatia Award for Best Clinical Research in Child and Adolescent Psychiatry in India in the biennial Conference for Indian Association of Child and Adolescent Mental Health 2019. He is the founder of Aram Mental Health Clinic on Pune, and he is consultant child and adolescent psychiatrist at Minded Tilak Road, Pune, and he is also consultant child and adolescent psychiatrist at Mindsmith, Gurgaon. With this, thank you all. I'm handing the session to our esteemed speaker, Dr. Ritik Chatterjee, with this. We will take questions in the chat box. After the session, we will discuss about the questions one by one. Just put your questions on the chat box. Thank you very much.
Dr. Gopal, I think if he has joined his comment, his opening remarks,
Dr. Gopal is with us.
he's
If
Yeah,
he's there,
am
he
I
can raise
audible?
his hand. Yeah, he's there.
Yeah.
So your
Okay,
opening.
just a minute. Yeah, just a minute. I've logged in with my phone. Sorry, sorry for the inconvenience. So, I esteemed the moderators and chairpersons of this nice program called Moving, and also Dr. Shobit, who is my dear classmate and my dear friend, and Dr. Jai Singh. Thank you for the opening remarks. and Dr. Ritwik Chatterjee, who is our speaker for the session. Uh, I'd just like to say a few words. Procrastination is probably one of the most encountered problems in our day-to-day practice, and we always, including ourselves, we are not free from procrastination. As Jason rightly told, it just comes in our everyday life, and it is one of the most commonly complained. And all of us, right from all phases of our career, we need to understand how to deal with this procrastination. It is not a disorder, but it cut across us many problems, many disorders, and one of the prominent symptoms, if we can put it as a symptom, so it has its own neurobiological underpinnings, and it has its um behavioral counterpart. And why people procrastinate, there are different types of procrastinators, which we are eager to hear from Dr. Twig. So I'm also eager to listen to the session, and maybe we'll open up the question and answer section later. We would expect a lot of questions on how to deal with it. So over to the speaker. We are also eager to listen to you. Thank
Uh,
you.
Thank you so much, sir. First of all, thank you so much for giving me the opportunity to talk about this. Now, I don't really claim myself to be an expert in anything. I'm just a student of psychiatry. Maybe I'm a expert in procrastination, and I know. But hopefully, we'll be able to talk about procrastination in detail, understand it as a clinical entity which has a biological underpinning. So, with that, I'm just going to share my screen. Get rid of this. Yeah. Okay. So, the procrastinating brain. We are going to take a deep dive into it. But before I start, I wanted to ask all of you guys, what do you feel, is procrastination a good thing or a bad thing? Because if you ever go and talk to the general people, you would frequently hear the thought that, okay, procrastination is a superpower that I have. I am not very sure about that, but I would like the audience to kind of give me a comment. If you feel that it is a superpower, type 1 in the chat. If you feel that it's not a superpower, type 2.
I've taken a third choice.
I think everyone is taking a third choice.
No, both my co-moderators have.
Yeah. But as we can see, there's a lot of people saying 1 as well as 2. There's 1.5 as well, 3. Okay. So I think most of us agree that procrastination is something which can be good in a few places, bad in a few places. How can it be good is something a lot of us find hard to believe. But let us first talk about the bad. Okay. So going ahead with that. So first, I want to kind of define procrastination and compare it to motivation. For procrastination, basically what we're looking at is it is avoidance despite anticipated negative consequences. While for motivation, it is more of a reward-driven goal, which is initiated by dopaminergic pathways in the nucleus accumbens. So the key line is basically that procrastination is not low motivation. It is more of a failure of top-down control over threat-responsive circuits. So what's the significance for us? So first of all, even if you just look at the general people without any disorders, almost 20% of adults report chronic procrastination, which can impact daily function and treatment adherence. Then procrastination is linked to non-adherence in a lot of different treatment conditions. The third thing is, whenever we are looking at any kind of psychiatric disorder, we are also looking at what we call as caregiver burden or caregiver burnout in their caregivers. The exacerbated burnout also causes procrastination and delays crucial tasks and self-care. So let's first try to understand it from the network model. So the core concept is there is a network imbalance when there is the interaction between default report network, central executive network, and salience network. Again, now we are able to look at procrastination as a clinical identity where we are able to understand what kind of action is going on in the brain. Coming to the first one, default mode network. So DMN activity, basically the role of DMN is it's a self-referential thing. And what we understand is increased DMN activity at rest is consistently observed in chronic procrastination. And this causes basically excessive self-referential thought and mind wandering, and it contributes to task disengagement and avoidance behaviors. Coming to central executive network, so what we usually see is the DMN has actually increased in its functioning, but coming to central executive network and salient network, they actually decrease the function. So in CEN, what we see is there is reduced connectivity between DLPFC and nucleus accumbens. This impairs the ability to compute effort and execute tasks, which is a key feature in conditions like depression and evil. The example is, for example, in traumatic brain injury or ADHD, the CN's executive control is weakened and it contributes to difficulties in planning and task execution. Next, going on to salient network. With salient network, what we usually see is there is a hyperactivity or dysregulation of the switching part that it does. When the main work of salience network is to switch from DMN to CN so the person can go ahead with the task. But when the switching is bad, what we see is there is a dominance of the DMN, and this hinders the transition to task-oriented behavior and promotes procrastination. So just to again summarize what we talked about, the dark ones are basically procrastinators and the light blue ones are normal population. The DMN activity is increased, CNS activity is decreased, and salient network connectivity between these are decreased. Okay, so this is just for the procrastinators. Right now, I'm going into how I would explain to an expert in our field. But I understand there are a lot of students as well as a lot of people who are not psychiatrists here. So for you guys, I'm going to do a small presentation of 9 slides just to compress all of this into things that you need to remember. So it is okay if you zone out here. Okay, so quantitative biomarkers and genetic architecture. So like I said, we are now finally able to understand what is happening. So if you look at MRI or functional MRIs, the ratio of DMN and CN functional connectivity shows a very strong negative correlation with task completion. This is something which can serve as a fMRI-based biomarker for procrastination. If you look at structural integrity, so DTI can assess the structural integrity of white matter tracts connecting the anterior insula to TLPF. Again, it can provide insight into the SN and CN communication and its role in procrastination. So these are biomarkers that we can start using. Then there is heritability. So there is approximately a 46% heritability when we are looking at procrastination, and there is a significant genetic predisposition. And whenever we are looking at the genetic architecture, we are mostly looking at involvement of genes related to either dopamine signaling or serotonin signaling, which either regulate reward and motivation or mood. Additionally, stress response pathways are also implicated. So genetic factors can contribute to that as well. So now we'll go from basic to a bit advanced. So how do we go from genes to circuits? To give you an example, this is DRD2 ANKK1 TAC1A allele. So the A1 allele of this gene is associated with reduced trityl D2 dopamine receptor availability. Now, when that happens, there is a diminished response to rewards, and this basically makes an individual less motivated by delayed gratification. So these kind of people are going to present to you with low motivation from the beginning of their life. Other clinical relevances, as they go on to an older and older age, these people also go towards Parkinson's disease, and there is a significantly poorer response to dopamine agonist in these patients. Another example is COMT Val 158 MET. So the Val genotype basically leads to increased activity of COMT enzyme, which is responsible for breakdown of dopamine. And if the dopamine breakdown is quicker in prefrontal cortex, what we see is impaired cognitive control. So things like planning, working memory, inhibition, these are changed. And this actually contributes to impulsivity as well as task avoidance. So the other thing is these people who have this genotype have a significantly higher, almost 3 times high risk of procrastination, particularly if they have a condition like ADHD due to compromised executive function. Coming to, these were the dopaminergic genes. Coming to serotoninergic genes. So 5-HTT-LPR-SLE. This is a gene which is associated with heightened amygdala reactivity. And what that leads to is increased threat perception and a stronger tendency towards avoidance behavior when faced with very challenging tasks. Another example is BDNF MET66. So the MET66 variant of BDNF gene leads to reduced hippocampal neurogenesis. This impairs the ability to vividly imagine future rewards and consequences, which hinders motivation for long-term goals. Whenever we are talking about impulsivity, we nowadays look at what we call as the polygenic response. So polygenic response is basically you're looking at different genetic variants in the genome, and you're using it to kind of score as a what kind of risk the person has for impulsivity. The thing is, for impulsivity, a higher ERS score is significantly correlated with increased procrastination behavior. So you're looking at a complex genetic architecture which underlies task avoidance. Coming to neural circuits, dopaminergic circuits. So dopaminergic circuits, the main work is basically reward and cost benefit analysis. The mesocortical pathway basically looks at the cost benefit analysis, and the VTA2 nucleus accumbens basically leads to reward and motivation. So dysfunction in both of these. So the reduced VTA nucleus accumbens dopamine leads to a blunted reward anticipation, and it again makes tasks much less appealing. There is also decreased D1 receptor activity in PFC, which can impair the ability to accurately weigh the costs and benefits of action. So again, it leads to decision paralysis. Coming to glutamate and GABA. So whenever in chronic stress, we know that chronic stress elevates prefrontal cortex glutamate levels. Now, glutamates are primarily inhibitory, and because of, the glutamate is primarily excitatory, and it can lead to uh, dendritic atrophy and compromised executive function. Amygdala glutamate. So increased glutamate in the amygdala, it can enhance the fear and anxiety response, again promoting avoidance behavior. So what we see is the balance between GABA and glutamate is very critical for optimal prefrontal cortex function. And any disruption in either of these can again cause significant contribution to procrastination. Coming to neuroendocrine influences. So for cortisol is something which is increased in chronic stress. And what that leads to is glucocorticoid receptor saturation in the PFC. Now, this diminished activity will actually again impair executive function for task initiation and completion. While with oxytocin, we have a reverse thing. In fact, in studies, oxytocin given intranasally has been shown to increase outcome of trust. So trust about what the outcome is going to, and fosters a willingness to commit to future action. This can significantly reduce delay discounting and task avoidance and promote goal-directed behavior. So maybe intranasal oxytocin sprays might be a good thing to carry around. Coming to epigenetic and metabolic factors. So for epigenetic factors, one example is the FKBP5 methylation. So the methylation of FKBP5 gene can lead to increased glucocorticoid receptor sensitivity. Again, this will lead to altered stress response, which will lead to impaired PFC function. And again, it impairs executive control. Mitochondrial dysfunction. So interestingly, if there is decreased mitochondrial efficiency. So again, what that's going to do is decrease the efficiency of the prefrontal cortex, and it can impair the brain's ability to compute and sustain effort. Again, contributing to a reluctance to engage in demanding tasks. Dynamic interactions. So basically, what we're looking at is these genetic factors leading to proneness in a few areas and few circuits, and the interaction of these circuits with the environment leading to procrastination. Coming to clinical implications. So now we'll talk disorder specific. I'm not going to go through all the disorders. Just again, we are keeping it basic so that it's to understand the concept. So ADHD. So ADHD is characterized by deficient dopamine signaling in the frontostriatal circuits. Now, this leads to exacerbated delay in discounting, where what happens is immediate smaller rewards are disproportionately preferred over larger delayed ones. Again, this is a hallmark of ADHD as well as a hallmark of procrastination. What's the treatment? So methylphenidate, it's a common ADHD medicine. What it does is it enhances the activity of the central executive network, thereby improving attention, improving impulse control as well, and helping in task initiation, thereby mitigating procrastination. So again, it's pretty simple when it comes to something like ADHD. Let's talk about depression. So in depression, what we usually see is there is a overactive default mode network coupled with diminished salience network, which leads to persistent rumination and a reduced ability to shift from the DMN to CN by SN. So this goes for reduced ability to shift away from internal thoughts. Coming to a cellular factor, decreased BDNF again impairs hippocampal neurogenesis and synaptic plasticity, which again directly affects the capacity of future planning and goal-directed behavior. So this is what we usually see in depression. Coming to anxiety disorders. In anxiety disorders, what we're looking at is more of amygdala hyperactivity. So elevated activity in the amygdala, the brain's fear center, drives a profound threat bias, which again leads to exaggerated responses to perceived dangers and hinders rational assessment. There is also salience network failure. The anterior insula, which is a key component of salience network, fails to effectively switch to salience, again leading to cognitive reappraisal. And this traps that individual in a cycle of anxious thoughts, which keeps going on. And again, given activity increase so that rumination increases as well. Coming to something like Parkinson's disease, you are looking at the degeneration of nigrostriatal pathways, where after one point, we start getting what we call as cognitive bradykinesia. So thinking is slowed, processing is slowed, initiating cognitive tasks is slowed. All of these are, and the intervention which helps here is actually treatment strategies involve dopamine agonists to replenish dopamine level. Another example is traumatic brain injury. So traumatic brain injury often results in damage to the dorsolateral prefrontal cortex because it's on the outer side. So this is a critical region for executive function. And whenever there is trauma there, it can lead to significant impairment in planning, decision making, and working. As a biomarker, we can use GTI here to understand whether the integrity of the white matter tracts within the CN are present or they are disrupted. Again, providing objective evidence of TBI related jam. I was talking to you guys about caregiver burden. Here I'm specifically talking about the dementia caregiver case study, but this is true for basically almost all of our psychiatric disorders. If you look at it, there's a 68% people or caregivers who exhibit pathological procrastination, which is a maladaptive coping mechanism that severely contributes to burnout, emotional distress, and reduced quality of sleep. You can use the Zarit burden interview, which is a tool used to quantify caregiver burden, or we can use functional MRI, again, which can help us understand the neural correlates of caregiver and executive dysfunction. So, to give you a kind of differential diagnosis framework, whenever you're looking at procrastination, the first step would be to rule out affective disorders. Want to clinically assess and exclude any primary diagnosis of depression or anxiety, because again, these can mimic executive dysfunction. These are probably important for almost 85 to 90% of the cases of procrastination. When we are not looking at those, then you are looking for developmental disorders where you are checking for the integrity of connectivity of the frontostriatal circuits, again, which are crucial for executive functioning. So you can use a fMRI or DTI. If you are not seeing major like findings there, then the third step would be to consider specific genetic testing for polymorphism in genes relating to, first of all, dopamine metabolism, serotonin metabolism, and stress risk. Talking about evidence-based treatment, so again, I'm not going through all the meds. We will be discussing further about the medicines in our discussion. But just to give you an example, you're facing a child with ADHD. Methylphenidate is known to cause increased dopamine and norepinephrine in prefrontal cortex, which basically boosts the central executive network activity and improves cognition. In depression, vortioxetine, we all know, has been pushed for improving executive function. But I can tell you, in my personal experience, I've seen the same kind of response to almost all, most of the antidepressants. In anxiety, pregabalin has some amount of evidence because it reduces hyperexcitability in amygdala. But there was an interesting there is an interesting case study going on in Netherlands. There's a Netflix documentary made on it. It's called A Cure for Fear, where the doctor used propranolol for reducing the hyperexcitability of the amygdala, which helped in not only decreasing fear and PTSD symptoms, but also somewhat in uh, procrastination. Neuromodulation. So EDCS, RTMS can also be used. They are mainly used to stimulate the dorsolateral prefrontal cortex, because again, those are the most exposed areas. And the DLPFC activity will lead to increased central executive network activity. You are mainly targeting the F3, F4 areas, which are the left and right DLPFC. And you want to give like a 10 hertz stimulation for 20-minute sessions. And this has shown promising results in enhancing cognitive control as well as improvement in procrastination. Future research directions, we can look at GTI as something to look for in DMN and GN connectivity, along with functional MRIs and PET scan. There is an interesting point of epigenetic therapy. So ADAC inhibitors, currently mostly used for cancers, which are epigenetic modulators, and they reverse adverse gene expression patterns. These can possibly also have a role to play in this. Finally, mitochondrial boosters. We talked about decreased mitochondrial efficiency in the PFC, leading to more executive discontrol. So, if we use things like mitochondrial boosters, what we can do is we can improve the neuronal energy metabolism, thereby increasing the overall functioning or energy efficiency of the prefrontal cortex. And again, it helps in elevating executive dysfunction. So this was the first presentation. Now, this was mainly for our psychiatrists who are well into practice, have a good understanding of what kind of things they are looking. But again, being a procrastinator, I made a cheat sheet. So this is more for those people who are who are students or residents, maybe other students in other fields who are interested in this topic. So again, just to compress all of those, am I able to share?
You're sharing the old slides only.
Oh, okay,
You
okay.
have
I
to
just
stop
changed
this
that.
share
Yeah.
and then
All
close
right.
this PPT
Yeah.
and start the next.
Got it.
Yes, now you can.
Yeah. So this is more for the students as well as those people who have just started their understanding about these symptoms. Okay, so the core definition is uh, voluntary delay despite negative consequences. And like I said, it is driven by emotional avoidance. In depression and anxiety patients, 94% patients report procrastination. And there is a 60% effect size of procrastination, which predicts poor therapy adherence. So even if you're undergoing therapy with a patient with depression, anxiety, and procrastination, very high chances of dropping out. To simplify the triple network model, you're looking at DMN. The main role is self-reflection and rumination, and increased DMN activity leads to distraction as well as more rumination. You're looking at central executive network. The role is more of planning and focus. So the dysfunction is there. It decreased CN activity leads to poor task initiation. And you're looking at salient network. The role of more is basically triaging, so shifting from DMN to CN. When it fails to suppress the DMN, it leads to decision paralysis. Genetic vulnerabilities, we are looking at some genetic disorders, for example, COMT valval phenotype, which can lead to decreased PFC dopamine, which can lead to poor focus. Here, stimulants are more effective. We can look at 5-HTT LPR mutation, which basically leads to increased amygdala reactivity and avoidance. Here, SSRIs, exposure therapy, as well as propranolol do better. You're looking at BDNF MED66 gene, which decreases the planning for future and delayed rewards. And here, behavioral activation becomes critical. So in something like DMN, in something like depression, you are looking at DMN dominance leading to rumination, leading to paralysis. So something like vortioxetine, which leads to DMN suppression, along with behavioral activation, will help you. In ADHD, we're looking at something like CNS weakness, which is leading to impaired planning. So methylphenidate, along with time awareness training, will help. In anxiety, you're looking at salient network failure leading to threat bias. Again, here, something like SSRIs along with CBT for reappraisal or propranolol or pregabalin can work. For assessment tools, behaviorally, you can look for delay discounting task, which uh, shows high impulse, which is seen in high impulsivity. There is a procrastination assessment scale which you can use. If you are neuro-informed, then fMRI can lead you to understand the decreased connectivity between DMN and CN. And EG, the theta beta ratio in PFC, can lead you to understand whether there is a ADA delay. From a pharmacotherapy point of view, if there is emotional avoidance, you're looking for antidepressants, which leads to decreased amygdala hyperactivity. If there is prominent executive dysfunction, you're looking for something like stimulants, which leads to increased PFC dopamine and central executive network boost. Finally, you are looking at rumination, where vortioxetine nowadays seem to be pushed quite a bit. But like I said, I'm seeing similar results with most of our other antidepressants as well. It decreases rumination by DMN suppression. Psychotherapy strategies. So in CBT, what you're looking for when you're looking at anxiety, you're targeting amygdala. So you're trying to do the salience network retrain. And there is decent evidence that that can lead to decreased procrastination. When it comes to behavioral activation, um, you are looking at more of CEN dysfunction. So you are trying to initiate action in the CEN, which leads to more dopamine release. And the tip here is basically the 5-minute rule to overcome inertia. You tell the patient to just do one thing for 5 minutes, not more than that. If you want to continue, you can continue after that. But the thing is, if it is a small, it seems like an achievable target. If, for example, he wants to exercise, ask him to just start with 5 minutes. If he feels like it, he can continue after 5 minutes. You'll see that most of the patients actually are able to help themselves overcome inertia unless they have very severe symptoms. Clinical action plan. So key takeaway, you want to screen using the procrastination assessment scale. You want to target different networks. So DMN and hyperactivity, you want to target via mindfulness or SSRIs. CEN weakness, you want to target via stimulants or TDCS. Salient network failure, CBT for emotional regulation can also help. So again, you're looking to integrate pharmacotherapy as well as neuroplasticity tools. Do understand that none of these will work properly if you're only using one single thing. It's a issue which requires multiple approaches as well as sometimes multiple interventions working together. What are adjunct interventions? TDCS, which can help in DLPFC stimulation, can increase CN activity. And mindfulness can help in DMN down regulation, can decrease ruminants. And finally, exercise can help in increasing BDNF, which improves hippocampal neurogenesis, and that improves future planning and thinking. That was about it. I'll end my screen sharing here. And we move on to questions.
Thank you, Ritvik, for enlightening us, presenting a new perspective for many people. And so over to chairpersons for their opening remarks. Then we can invite the questions in the chat box. So please post your questions in the chat box.
Yes, thank you, Dr. Ritvik, for the comprehensive presentation. And you focused on so many things. First, you discussed about the different network involved in the procrastination. And after that, you covered about different genetic architecture, neural circuit, and neuroendocrine and epigenetic factors involved in this procrastination. And after that, you covered the different psychiatric scenario in which we can work by integrating pharmacotherapy and non-pharmacological methods to treat these symptoms. And you well covered all the aspects of this topic. With this, we will take some questions from the chat box. I think chat box is full of questions. More than 10 questions is here. So first question which I can see in the chat box is there any scale to measure it? I think you have already answered in your presentation that there is procrastination assessment scale by which we can go through that and see that what is the status of the procrastination of.
Yeah.
Sir?
Sir, I think Shamali is raising her hand. Shamali, you want to unmute yourself and ask a question?
I think we don't allow unmuting
Oh, okay.
for
Then
other
it's fine.
participants.
I think we'll go on with the questions then, sir.
Yeah, but she can type it in the chat. But anyway, one thing I wanted to find out interestingly about the scale which you mentioned, I was reading the year, it was 1984. They've not updated the scales after 1984.
They have not updated because, again, it is not looked at as a clinical symptom or something which is a diagnosis. And because it is only seen as a symptom of other disorders, so there's not a lot of research which is specifically focused on it. In only since the last few years, when we have functional MRI, PET scan, DTIs, and we are able to understand network origins of these things, that again interest has gone back into.
Do you think there's a need for a scale like that? A new scale?
Definitely, but again, see, the issue is you're looking at one symptom which is common between a lot of different disorders. Now, whether like I'll give you an example. Let's say that I have depression. So I like to explain to my patients in this way that what's happening is there is some kind of a neuronal dysfunction or something like wear and tear to your brain. Now, what that's doing is it's kind of decreasing the available resources which the brain has whenever it's trying to process anything, make any decision. So, what the brain goes or does at this point is it goes into what I like to call survival mode. Survival mode is something like using, if you guys have used it, the Windows ka safe mode. It has basic things in it. It has most of the functions are there, but you're not able to use advanced function. So task avoidance becomes something that is secondary to that. So anything which requires a high cognitive load, so my brain will tell me, okay, I don't want to do this. So one example is, for example, uh, this is something I see very frequently in a lot of patients, that when they're watching something, they will not pick up something new to watch. They're going to watch the same thing that they've already seen. Why? Because at that time, the brain doesn't have to put inside new information, doesn't have to process as much. It's just repeating the previous processing which was going on. So it's an easier cognitive load for the brain. And the brain is a very smart organ. It understands that if I do more work, I'm going to lose even more resources to wear and tear or cellular dysfunction. So I have to save all of my resources as much as I can. So it's more of survival. But compare this to, say, procrastination, which happens due to the decisions we take. I'll give you an example, and this is something I think a lot of us will understand very clearly. That so mm, for me, my brain kind of functions from school time. I understand I process things a bit quicker. This is something we see in a lot of brains. Typical examples you will see in 3 घंटे का paper रहता है. These people will finish it off in 2 hours, and then after that you'll sleep for 1 hour. This is a very typical picture we see. And what these guys do is, so for them, studying something for an exam, if other people are finishing it in 2 days or 3 days, these guys are able to do it in 6 hours, 8 hours, 12 hours. Now the brain is making that as a checkpoint. It knows that you don't need to read for 3 hours. This is something I used to frequently face in my MBBS years, that people are studying like way before the exams. They're repeating, they're doing a lot of hard work. And my brain is telling me कि अभी time नहीं आया. You wait. And then exam ke just pehle, suddenly you'll get that huge hit ki, okay, you need to now go into high focus mode. And you've gone into high focus mode and you try to finish as much as possible. Now, the caveat is, if I had something like anxiety at that time, it would lead to decision paralysis. So I would lose that 6 hours of high efficiency as well. But in this kind of a situation, if the brain is actually functioning well, it is making a what we call as a calculated risk. So how do we compare these two? I'm still not very sure whether they should be compared as well.
Ritvik, so supposedly we take a very simple scenario. So where there is a patient comes to us by a complaints of delaying tasks and procrastinating. So what should be the symptom analysis? What all the various possibilities will consider? Because after looking at your presentation, it is restricted largely to mood disorders, anxiety, and attention deficit hyperactive disorder.
Exactly. So
So
these are the
anything-
most common things that you will see. Like I said, 90 or 85 to 90% of your cases will actually fall into these, and the treatment is pretty simple. All you need to do is give them uh, something to improve the like hyperactivity of the limbic system. So decreasing amygdala activation, something like SSRIs or propranolol, and something to improve the functioning in central executive network, which is going to be methylphenidate, atomoxetine, modafinil. So this is a general concept that you can use across different disorders. For example, uh, you see a person with dementia who has basically lost a lot of cognitive functioning, and they are not able to really do any more things. They don't feel motivated to do many things. So something like methylphenidate has a very good role there. In fact, once you start methylphenidate for those people, they suddenly become as active as they were 10 years ago. So my first thing would be to rule out all of these. If you're not in this category, which is again going to be the most biggest, largest community, if that person is not in that, then you are looking at probably a neurodevelopmental disorder. So now you want to start looking at neurodevelopmental areas, whether that motivation has been low since his childhood, whether it is something which has come recently. Again, if it is something which has come recently, you're definitely looking at a component of uh, um, MDD or anxiety, or what I like to call neurodegeneration. But when you're not looking at something like that, you're looking at a child who is from the beginning someone who has had very poor motivation, then you need to look further. Here, you are going to look for uh, things like connectivity between the salience network, DMN, and uh, central executive network. So something like functional MRI or PET scan would help you understand. Again, do remember that these will respond to different interventions. It's not that they will not respond,
but
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 it will let.
yes, but we don't use the this procrastination context of psychosis or in schizophrenia, because we consider that the motivation levels are to an extreme, apathy, anhedonia, and those negative symptoms. So are they in spectrum of intensity? We can conceptualize them in that sense.
Yes, definitely, because see, again, for me, what I'm looking at things, see, I'll tell you something. I'm very bad in memory. I have an issue with memorizing most. And because of that, memorizing diagnostic criteria is just out of there. I have a DSM pocketbook with me. So I just open it. I'm like, ye wala hai, right? But the point is that when you are looking at something like psychosis, what we call basically the anhedonia, amotivation, aphasia, even the like 5 A's that we talk about in schizophrenia. All of these are what we call as negative features. These are basically telling you that the central executive network is not functioning. And this is actually telling you that there is something which can help you. So actually, a trial of methylphenidate for these kind of patients do seem to work. I have actually tried it. I have tried it in psychosis. I have tried it in these, and in fact, a lot of patients with psychosis, what I tend to see is if we go back and trace back to their childhood, we usually see some features of attention deficit. It is a pretty strong correlation that I've seen in my practice. If you go back in psychosis and you look back, these guys are sometimes, not sometimes, I would say majority of times, you will see something like attention deficit there. So it might be that we are just fixing that developmental disorder which was there. It might be that since we are increasing the functioning of central executive network, so the patient is responding better. But yes, there is a huge scope of doing this. Only thing that I have to give as a disclaimer is you do not want to do this when the patient is acutely psychotic. It will worsen the condition.
Well,
So
how
only when the acute psychotic features are under control, which means the hallucinations are very low, he's not physically aggressive, you're seeing more of negative features, that is the place that you can think about either adding a stimulant. The other thing that you can think about is adding something like a cognitive enhancer like memantine, amantadine. They actually pretty work pretty well in psychotic features as well.
Okay. Shobit, can I ask? Yeah,
yes, yes.
yeah. So Ritik, going back to extreme basic, the first question you asked, in what condition it is beneficial, in what condition it is harmful? Let's start from that.
Okay, so we talked about most of the harmful conditions. Like we saw, most of our psychiatric disorders, there, if the procrastination is seen, it becomes something like a pathological thing. Uh, when we call it pathological is when it is affecting day-to-day work, when it is something which is affecting the person's performance at work or home, and it's a significant thing. It is causing significant distress, significant dysfunction. He's getting complaints from a lot of places. So this is the typical picture we usually see. Now, I already gave you an example of the advantages of procrastination. Uh, that is when the brain is actually in a good state. It's not in a bad state. Like it's not in a diseased state where it is struggling to have good processing about components and tasks. It is something which can actually promote high level of efficiency. So you'll frequently see these kind of people come out in crisis situation. So these procrastinators who you will, this is a common picture no matter where you see. You'll see in teams, you'll
So
see
that
in
is, Ritik, that is because of procrastination or because of the time crunch that was initially caused by procrastination?
no. So the thing is, it is not due to procrastination, but the procrastinators are well equipped to do this because
Okay.
the brain has been
If if
practicing.
if they are surviving well in the community in their
Yes, yes.
lifetime.
So
Okay.
because
So if
they've
a
been
person is
practicing this. For
yes,
other
so
people, they are used to making some plan, making some action, do some things. Those people who are procrastinators, they are very, very well suited for these high efficiency work where you're going in. Let's say there's a sudden earthquake. You're going in working for like 6 to 12 hours at extremely peak efficiency. Other people are going to get tired, but these brains have been trained to actually do this. So
okay.
it's
So a
one thing
person
that
who
it, yeah.
yeah, a person who is actually well adjusted and a procrastinator, he will have these episodic bursts of extreme efficiency.
Yes,
That is
and
the
they
summary.
are one of the best people you can hire for any crisis management situation.
Okay, okay.
In
Now
fact, they
tell me,
shine there.
yeah, okay, right. Tell me whether how the brain is functioning. Procrastination is not a passive process, it is a very active process.
Yes, definitely. So we are looking at interactions at three different levels. First interaction is at a cellular level. So genetic disorders or are psychiatric disorders or neurological disorders. All of these are well known to cause s- uh, cellular dysfunction or neuronal dysfunction. So you are looking at a place where the cellular dysfunction is there. Circuits, because of cellular dysfunction, are not working to their peak capacity. We can even trace back to something like mitochondrial disorders, where again, decreased mitochondrial efficiency leading to decreased neuronal efficiency, leading to decreased efficiency of these networks. So, these neuronal deficiencies or dysfunctions will lead to dysfunction in small scale networks. These small scale networks will lead to dysfunction into the large scale networks, and these large scale networks are what we are able to see via DTI, fMRI, PET scans. And the output of these large scale networks is what we are calling as symptoms or procrastination. So it's a complex like condition. Again, see, for example, the environment also plays a huge role here. So the environment decides the cognitive load. The cognitive load will then decide whether the uh, as like our alien network will be able to switch to that task or not. So this is going to lead to decision paralysis. It's a huge cognitive load, and the brain is not in that good state. The cellular functioning is not that great. It is going to immediately avoid that task. It's going to go for a
So
task which
basically,
has this. Yeah.
basically they are not lazy, they are just confused, you can say, overwhelmed.
Yes. Overwhelmed,
Okay,
confused.
just one small question. Suppose we talk about procrastination as a topic now. Now, procrastination in depression is same as in ADHD, is same as in other disorders, or procrastination in various presentations is a different flavor, or it is the same thing presenting.
I would consider it to be more similar than different. Yes, there are definitely differences at a neuronal level when you're looking at it. There would be definitely differences at smaller scale networks. But when we are looking at the large scale networks, large scale networks are basically you're looking at multiple smaller networks which are aggregated together. So they are aggregated so much that they are able to create, and we are able to pick up the electrical changes or the metabolic changes which are happening. And these large scale networks are what we can correlate with procrastination as of now. So my suggestion would be to take it as the same thing in most of these. Like I said, there are going to be little subtle differences. But for those, we need better investigations. We need to have better imaging techniques, functional imaging techniques. And if we are able to do that, we should be able to actually define procrastination with each disorder. But again, if we are doing that, if we get to that level of technology, I'm not sure whether depression will stay depression. It might get split up into multiple different disorders based on those microcircuits.
Ritvik, interestingly, when you said emotional avoidance, it leads to procrastination. But we see a lot of patients with anxiety predisposition, and they have a very difficulty in saying no, and they'll actually do things to the point that they take themselves to a lot of burnout, and they immediately will do, and then that is a bigger point of contention, and then brought by families that they're anancastic OC traits. There is a related question in the chat box. So your take on this, then it
Yes.
becomes little
See,
interesting.
what's happening here is actually pretty interesting because uh, someone who is extremely emotional and who goes for something like this, what is happening in the brain, according to me, would be that first of all, there is a high cognitive dysfunction. So they don't have a lot of good, like efficient systems to work with high cognitive loads. Now, what's going to happen is there are going to be two type of people here. Few people, actually most people, they are like me. For example, let's say I go into psychosis. If I go into psychosis, I'll go into paranoia and I'll just like hide away from everyone. मैं किसी के साथ पंगा नहीं लूंगा because I'm like ये मेरे को मारेगा वो मेरे को मारेगा. There is a second subset which is a smaller subset जिनको मैं दबंग subset बोलता हूँ. These guys, they're like, तू मेरे को मारेगा नहीं नहीं मैं तेरे को मारूंगा. So they actually are those people who have high motivation from before, and these guys will not go for this. The previous part or the majority part are going to be those people who are well used to avoidance whenever there is some cognitive load. So for these people, the salient networks actually calculates. So it's going to calculate whether what is the higher cognitive load, whether doing the task is going to be higher cognitive load, or whether actually talking to the guy and explaining to him that this is not a good idea, I don't think I'll be able to do it. And then if he says something, now I'm already ruminating and overthinking. So I'm already imagining in my head that if I tell him that I don't want to do this, he's going to tell me why ऐसा क्यों करके दिखा, and then I'll have to pick up something else. So that becomes a higher cognitive load for these guys. For these guys, the immediate cognitive load in saying yes is lesser. Although, because of this, the cognitive load later is going to be high. But salient network is not very efficient in looking for long-term things. It's looking for immediate answers for immediate situation. So here, there, the cognitive load for having an argument with that person or trying to explain to that person that I don't want to do this is going to be a higher cognitive load. So he's avoiding that because.
Okay. Okay. Now, Vishal boss.
Questions in the chat box we can take.
Yes, yes. Dr. Ritvik, my question is from the layman perspective. If someone comes to me in a remote area where there is no facility available for psychotherapy, CBT, or any behavioral therapy, and patient comes to me with the single complaint of procrastination, and he is telling me that he tends to procrastinate so much that even his work delays so much, and he don't want any medicine for this. So what are the common non-pharmacological method available for him, because there is no availability of psychotherapy here?
Yes.
ठीक है?
So
I'm attaching one
psychotherapies,
question from
the thing with
chat box.
psychotherapies, I feel is that a good psychotherapist is someone who's going to personalize the whole therapy for the those specific symptoms. And if it is someone who is neurologically informed, they will be able to correlate with the neurological conditions and they'll be able to do it. So the first thing in this kind of a situation would be for me to assess for again anxiety and depression. This guy, if there, see, if you are looking at any place where there is dysfunction in daily life, then you are definitely looking at some kind of a disorder. Maybe it is developmental, maybe it is something which has come later, but chances are that it is going to be something which is a disorder. Now I always like to explain to laymen like this कि यार आपका ना सॉफ्टवेयर प्रॉब्लम नहीं है, ये हार्डवेयर प्रॉब्लम है. इट्स लाइक आप 2 GB का गेम रन कर रहे हो 1 GB के फोन में, तो इट्स गोइंग फॉर अ क्रैश बार बार. It's not going to be able to run those process. If we just put an extra RAM for it, it will start working well. So my suggestion here would be to first look for those, and I would say there's a 90% chance you will find something or the other, and explain to him that this is something which has a very good response with medicine. If we go only for non-pharmacological interventions, the response is going to be pretty low. But if you still want to do it, then we can go forward with that. Here, again, you are looking again, just you don't have to understand or explain to the patient what is happening, but you do have to understand for yourself. So you're looking at, again, my suggestion would be to think from the three network perspective. Do you feel there is an issue with DMN? As in, there is a highly active DMN, he's ruminating a lot, everything is leading to decision paralysis, and there are repetitive thoughts. Here, something like mindfulness based therapies would be helpful. Asking him to practice mindfulness is basically trying to train his DMN to be less activated. Okay. So that is one way to go about it. If you're looking at something like central executive network dysfunction, so here this guy is going to say that he's struggling with attention, he's struggling with motivation, he's struggling with doing his work. His speed has gone down, his work has gone down. So here something like that 5 minute concept is a good idea. Tell him to do that work only for 5 minutes and continue after that if he feels like it. And we see a lot of patients actually respond to this well. Finally, when it comes to salience network training, again, some CBT have some amount of evidence behind it. But yeah, as of now, I don't think there is anything, any non-pharmacological thing which can specifically work on the salience network.
Uh, Acha, but Ritvik, can you elaborate a relationship between procrastination and impulsivity, not taking into context ADHD as a prototype? So whether are they in different ends of an spectrum? Someone who's not procrastinating at all becomes impulsive and does an activity. So in that context, I want your opinion.
See, it is a complicated thing. That
Yes.
I can tell you for sure. Because there is definitely a good association between high impulsivity and procrastination. But again, in this, I would say that we are looking at something like a phenotype. So whenever I see someone with high impulsivity, I see two different phenotypes. There are few phenotype, the one phenotype which has high motivation. So they have high motivation for everything. उनको बोला कि ये कर दो, they will finish it within 1 hour, give it to you, finish their task, and they're done, right? And this is actually a minority of the population. You will not see this in a lot of people. But I'm very sure that all of us have few people around us we know who are like this. उनका ये रहता है ना कि they want to finish everything at the beginning and then spend the rest of the time lazing around. Then the other subtype. The other subtype is some people who are raised with poor motivation. So for them, the impulses come, but these impulses don't translate into actual actions. So these guys will commit to everything. These guys will plan a lot of things, but when it comes to execution part, they get stuck there. So what I've been able to identify, there are these two different groups, and when you're handling these, you have to handle them pretty differently. When you're facing someone with high impulsivity along with high motivation as a phenotype, they tend to be people who will go back and talk to anyone. They will say anything to anyone. There, the primary concern is actually to take care of the impulsivity because motivation is there for everything. But similarly, the other subtype where they are low motivations, here you don't really worry about the impulsivity part. Here, the decision paralysis is not due to them being impulsive between different things. It's more that they get a motivation to do something and they get an impulse to do something, but they don't have the motivation to follow through. So these guys are, so if you're looking at group projects, you will see that there will be these two people in every group. There will be one person who you've told them, so they will take an active participation. They will go into a lot of different things. I think a lot of our admins are in that category. And there are going to be some people who are going to be there who will only work when you're pushing them. And they will tell you that I need to be pushed. I don't do it otherwise. So those are the low motivation people. So I would not directly correlate impulsivity with like procrastination. Definitely, there is a significant amount of association between these two. But when we're talking about causation, I would consider them to be a separate identity. First thing. Second thing is, when we are looking at neurodevelopmental disorders, specifically if you are looking at neurodevelopmental disorders where the dopaminergic pathways are being like there are variants of dopaminergic pathways. They are not made in the normal sense. You can see some dopaminergic pathways which have a high cadence, so they will keep working all the time. So these are the high motivation guys, and there will be those ones where the cadence is low. So this will be the low motivation guys. We can divide the groups into these two and plan an intervention accordingly. But yeah, I would not directly correlate.
But I think, sir, Ritvik has given us a fantastic idea for the researchers and young researchers about a scale for procrastination. I think Dr. Gopal will immediately jump onto this. We'll plan with
That
his
would be great. I do feel that there is a good need of that.
Yeah.
If we can actually do
Yes.
some kind of a study which correlates that to symptoms or maybe even something like neuroimaging, that would be a great project.
I think one last question from my side. You said about in your clinical approach, you said about genetic analysis subsequently. So what gene on testings will order actually? Whole exomes generally will not.
Not really recommended at this point. We know too few genes. So couple of genes I mentioned here. There are a few other genes that we are actually looking for. So see, the thing is when you're going for genetic testing, if you understand what kind of genes you're looking for. So here we are looking for three groups primarily, which is the ones with dopaminergic pathways, the ones with serotoninergic pathways, and finally the stress related pathways. So these three we can specifically look for, then the cost of the genetic testing will not be very high. But in actual clinical practice, chances are it might not be from one of these three. And I will tell you that usually we have to go for something like a whole genome sequencing or a whole exome sequencing, sometime both. And even then, there's like only a 20% to 30% chance you'll find something. The problem is the gene comes, okay. But the variant that comes, most of our Indian genetics has not been studied. So आपको मिलेगा वो gene आया है, but the report will say variants of unknown significance. So you're stuck in the same place, and you made the patient spend almost something like 1 lakh for that. So it doesn't make sense to do it as of now. Of course, there are going to be some people. If, for example, Ambani ka beta आया, मैं तो कराऊंगा यार. I'll be happy to do all of those, but I would not suggest it for a common patient.
Just to add to that, again, I was thinking about the same thing when you mentioned genes in your presentation, how specific these genes are. Are they really, really specific?
They are specific enough that you should test for. Because they not just tell you about the procrastination, but they will also let you predict future symptoms, which is actually going to be the primary thing here. It's
So when you're
not
saying,
the
so when you're saying,
procrastination.
sorry,
Sorry?
when you're saying a gene,
Yeah.
that means also you're saying there's a protein for
Hmm.
procrastination, right? A certain protein is malformed or not formed or whatever, right?
No, we'll never be able to find it because
Right.
again, when you're looking at procrastination, the only thing you can equate procrastination is to the output of those large scale networks.
Yes.
So now this is a result of multiple pathways which are going inside the cell, and we have very less understanding about those pathways. So if you're trying to look for a specific gene or protein, there is definitely we are going to fail. We need to be able to connect it to a higher level, which is
Absolutely.
basically at the network
Okay.
level.
Yeah, thanks.
Yes, yes, yes. It is an output of a complicated process, so not
Yes.
a specific thing. So I think we have covered all the questions. Anything
There's
important is left?
last
We're not
question.
covering some unrelated questions because some are unrelated. So relevant to the topic we have covered.
I think
So I
there.
think there is one question I just saw that I think I had kind of explained it, which is procrastinating. How is procrastination different from decreased energy symptom in depression? See, decreased energy symptom is something where you're looking for a lot of different uh, issues in initiating tasks. Okay. Again, this comes back to the definition of procrastination with versus motivation. In motivation, you're more looking for something like a push, and in procrastination, it is more of a top-down balance, which is problematic. So that is how it is different. Is procrastination increased by the decreased energy symptom? Definitely. But again, when you call something decreased energy symptoms, you have to be a bit more specific. I would not really say that that is a term which can be used easily.
Can there be selective procrastination, like a combination of both subtypes of motivation levels? Dr. Anupama wants to know.
Definitely, there will be, like I said, procrastination as a general thing we can understand as a uh, like interaction between the environment and the circuits, the tripartite circuits, which is basically the only thing we can do right now. But definitely there are microcircuits here which we are interested in, and once we are able to identify all of those, there would be specific procrastination pathways, and we would be able to something like I talked about those polygenetic risk scores. So possibly we would be able to have something like a risk score for these symptoms and different pathways. So if a person has 4 pathway dysfunction, the risk score increases. Chances of overall procrastination is way higher compared to someone having dysfunction on only one path.
Okay, I think we have covered all the questions. So to the chairpersons for the remark, then Tufan sir is there. Uske baad Tufan sir. Chairpersons.
Yeah, I'd like to uh, make a small remark. Before that, Dr. Ritwik, it was wonderful presentation. I was definitely, curiously listening to. I've not missed even one slide. Thank you for that. And I have one small question. Are there any novel medications that are in pipeline or any repurposed drugs other than the routine we do use SSRIs are probably the mainstay and stimulants as you have rightly put. You have mentioned some HPAC inhibitors. It's just a small uh, explanation. Is it?
The ADHD inhibitors, like I said, they help in epigenetic upregulation. So
Yeah.
that is definitely something we should look for. But I will say, sir, that we are not looking for novel molecules here. In fact, a much more interesting area is repurposement of older medicines. So something like I can give you an example. Something like desvenlafaxine is something I've used for increasing this motivation. Similarly, I have also tried something like amantadine, which worked for a couple of patients for procrastination. And I'm talking about young patients. You're looking at the age group of around 20 to 25, not more than that. So we are slowly looking at repurposing a lot of other brain drugs to these conditions, which can cause procrastination, first thing. Second thing, we are also looking at repurposing of other drugs from other systems which also work on brain, because see, we are now started slowly realizing uh, something we should have realized a long time ago, that whatever medicine we give, it is going to go to every single cell of your body, because although we are giving it for the brain, it doesn't mean it's going to go to the brain. Physics doesn't work that way. Diffusion is going to happen. Similarly, if we are going to give something for the heart, it doesn't mean it's going to work only on the heart. Even though we think, okay, we made a specific drug which only works on a specific receptor, you go back to embryology, you're looking at these the cells which are distributing into ectoderm, mesoderm, endoderm, further forming different organs, skin, heart, but they will have common things. So something I'm giving to the heart, I'm expecting embryologically they are closely related to the muscles, so there will be some effect on the muscle. Similarly, I'm also expecting that there will be some effect on the ectoderm cells as well. So we are expecting that something on which works on the heart will also work on the brain. We are slowly starting to see these because one of the common things is recently there was this one case. I'll just tell you. Yeah, trimetazidine. Trimetazidine is something which we use only for heart, mainly for chest pain, is now being explored for brain related symptoms, and it's showing very promising results in few brain related conditions. So again, we are looking at more of repurposed drugs, sir. Novel drugs, again, the cost of making a novel drug is going to be pretty high as of now. But with the help of AI, we have been able to do a lot more simulations before actually going into the actual clinical trial. And maybe we should be able to see the boost of AI in drug production. If that happens, we should be able to see many, many novel molecules come.
Thank you. That makes perfect sense. Uh, just speaking from this, maybe it's not just the medicine that we are probably targeting. It's about the understanding of, as you have mentioned, this tri network, and also basically we might be able to profile them. It's not that something that procrastination alone exists in any given patient. So if they might present with procrastination, but unless we understand the profile, whether they are cognitively or emotionally procrastinating, procrastination obviously is one thing that we are able to see, but why they are doing this. So when we understand the whole profile, it would be easier to decide on the management as well as therapy. I mean, psychotherapy, pharmacotherapy. That was one take-home message even I felt, probably to younger colleagues here. Um, it was excellent. I was really lost in listening to your presentation. And thanks the team, chairperson and chairman and moderators, and my friend Dr. Shobit, who have given this opportunity. I will not miss these sessions from now on. I'll make sure I'll attend. Okay, thank you so much.
Thank you, sir.
Again, Dr. Ritvik, wonderful presentation. How you separated two presentation, one for the expert and one for the residents and other people from the different specialty. How you describe about the network for better understanding and how you welcome the question and answered properly. I think you did a commendable job. And with this, thank you again, and thank you, moderators. And I'm now handing the session to the chairperson, Dr. Tufan Pati sir, for the concluding remark.
Thanks, everybody. Is Amrit there? Halim?
No, I don't think so.
Okay, I shall do both the roles. Hats up to Dr. Ritvik for your presentation. Just one doubt, one query. When the session started, Dr. Jaisingh told that this procrastination is also found in normal people. So when does it become symptomatic? Because or it becomes a disease. What is that soft margin?
I would say, sir, we stick to what we usually follow for any other disorder, which is you look for dysfunction in one of the fields, either work or personal life or future planning, something like that. See, I'll give you an example. In MSc, uh, whenever we are talking about judgment, we used to be taught there is social judgment and test judgment. And then after my residency, I found a lot of students come to me and they're like, what about personal judgment? Right? And personal judgment में जब आते हैं तो my doubt was कि यार I don't know this person. Who am I to judge this person or his person's life? Similarly, I think if we have to fix to a clinical entity, the best part would be to fix it as dysfunction. You're looking for dysfunction. If there is dysfunction, then you want to treat it. If there is no dysfunction, there's no need to treat it. You can call it a superpower.
Or
If there is a
distress,
dysfunction and if you can relate procrastination to that dysfunction,
Yes.
or
that
distress,
should.
sir. Context of
Yeah,
anxiety is also, sir.
Yes.
Okay, thank you very much. Thank you, Dr. Ritik, and thank you for your contributions, Dr. Gopal Das and Dr. Jai Singh, starting very nicely, and all the four moderators and all the people who have attended today. This exclusively beautiful presentation divided into sessions, 3 sessions together, 3 in 1, and that too done quickly. Congratulations, everybody. And
Thank you, sir.
over
Sir,
to
actually, I
Amrit
read
to
it one of the
over to
books.
Alim to close.
Okay. So one of the books I read it, Procrastination. I was reading one book. So there said that you ask the patient to write the next ideal day in the book in the night while doing some in the book and then sleep.
No,
I
this
don't
is
know whether it works or not.
it is
I also
real
bought a
red
book.
clear.
I also bought a book on procrastination. I still have to read it.
Varka,
Eh,
Dr. Varka. That is the
maybe Purchasing books and procrastination can be two things.
it's,
Maybe we are bothered about a procrastination or we want to know more about procrastination.
sir,
But when
Gopal was saying,
procrastination refers to long-term planning, it's very difficult to draw a margin.
so when we invited Dr. Gopal for chairing, I said, Dr. Gopal, it is a favorite topic of ours. We procrastinate a lot in MBBS. Come and join us. He agreed.
So I thank God I didn't procrastinate. When making a decision, I
नहीं
impulsively agreed.
यंग यूथ में जो था ना वो कभी कभी ये क्या वो ambivalence होता है. Whether this girl or that girl is ambivalent. It's not that procrastination.
So I think
Thank
something
you.
Oh, thank you,
everyone.
everybody.
Thank you,
Thank you.
everyone. Ending the
Thank you,
session
sir.
now. Thanks all of you. Ritvik, thank you so
Okay.
much.
Thank you so
I
much.
think I have a
Thank
topic
you.
for you. भी हम बात करते हैं.
Sure.
Thank you.
Dr.
Good
Jay,
night.
thank you. Thank you.
Thank you, sir.
Thank you, Jay.
Thank you, sir.
Vishal bhai.
Bye.
Thanks,
Gopal.
everybody.
Good night,
Bye.